Okay, so this is a person in their late 20s. They've had some kind of a procedure done for augmenting their bladder because they had a small capacity bladder and recurrent UTIs as a child. So when they were very young, when they were 7 or 8, they had this bladder augmentation. Nelly, you can see my screen, correct?
Yes, I can see your screen.
Okay, perfect. Okay, so I have very limited images because patient was very claustrophobic. So I have a sagittal T2, this motion limited axial T2, diffusion, and ADC. And
Was it
patient came with
augmented by a colon or augmented by the small bowel?
small bowel cookie. It was an ileal patch that they did.
Looks like there might be a mucinous tumor or something in there.
Exactly, spot on. So came in with hematuria and then they took him to cystoscopy, and then, like you said, this turned out to be an adenocarcinoma with signet ring cell features or a mucinous variant, which is apparently a known complication with these. The urologist said 10 to 15 years after they put in, they always counsel patients about this risk. It's only a 1 to 5% risk. There is a good article. I'll quickly share my other screen. Now I have to navigate this. Yes. I don't know what screen you can see, but anyway,
I
can
see
you
two side-by-side PowerPoint, kind of like that presenter's view on PowerPoint.
Okay, how about now?
Yes, now I see
Does it
your
show
augmentation
augmentation
cystoplasty slide.
Yes. So this is something they do for small capacity bladders, whether it's neurogenic, whether it's a scarred bladder from previous TB, chronic interstitial cystitis, obviously to increase compliance, reduce vesicourethral reflux. And like Cookie said, ileum is the most commonly used. They can use colon as well, and they can use cecum as well. But most papers now say they don't do this anymore because there are better techniques to manage small capacity bladders. But some complications to expect are because the bowel mucosa secretes a lot of bicarbonate, it makes the urine it changes the pH, so you can get into acid base imbalance. That then predisposes them to form stones. And then when they surgically hook it up, they call it bivalving, meaning the way the flow has to be let in is in a certain way. So if the bivalving is not done correctly, these patches can actually end up with diverticular formation. And the risk of malignancy is only 1 to 5%, but when it happens, it's usually an aggressive one. So this patient, it was unfortunate because he's only in his 20s and has ended up with this complication. So there's something we had not seen and heard about it in tumor board. Cookie, any other thoughts on this?
They used to do this with colon and they had a higher incidence of mucinous tumors. So they moved to small bowel and they still have an increased incidence.
Okay, I have another quick one to show. Let me share screen. Okay, this is sort of a combined MSK and body case. Patient with a known genetic abnormality. And I'll tell you what it is once we see what the finding is. Young patient also comes in with diffuse abdominal pain. And this is a finding we kind of only saw on arterial phase images. And I'll scroll slowly through the area of interest.
I mean, it looks like some angiectasia.
Right. So she's a known case of HHT, extensive AVMs in the subcutaneous soft tissues, and she has the cutaneous telangiectasias. She's been embolized several times for some neuro stuff. And then these were small telangiectasias seen very nicely on this arterial. Here's the portal venous. No, that's the chest, sorry. We didn't see it basically on another phase at all. And here's the chest. There were no pulmonary aviums that we could find. Incidentally, she also has extensive melorheostosis. It's bilateral in her, and I didn't find any association between, yeah, it's through the length of her body. Didn't find any association between HHTs and melorheos, but we,
Wow. What is
I,
that?
yeah, this is all melorheostosis, the candle waxy dripping. It's
Oh, I
typical,
mean,
right?
that's a great
Sclerotomal.
case.
Yeah. And these are small flea bullets. She has some hemangiomas at the bottom of her foot also. Yeah. So didn't find any HHT to Melorheo association. Um, Avastin is how some of them get treated, especially the liver ones, because they can end up with high output failure if the shunts are large in size. So IV bevacizumab. And for some of the larger bowel ones also, supposedly they treat them with IV bevacizumab if they're causing recurrent bleeding. This one, she is anemic. She's chronically anemic, so she gets repeated transfusions. So they're just monitoring her and repleting her iron as such. She's had several enteroscopies where they've seen some of these and they've sclerosed some of the bleeding ones previously. But as of on this episode, she didn't have any ongoing bleeding. So she was just discharged and continued with her supplements and such. So you have to have a first degree relative who has HHT. You have to have visceral AVMs, cutaneous AVMs, and recurrent nosebleeds. Those are the four, I think they call it the Cureco criteria. Those are the four diagnostic criteria. Apparently, there's a very nice radiology article from 2021 which goes through like the head to toe manifestations of HHT. That's all I have.
This is a very old, like, I don't know, over 7-8 years, Defeco, and this was before treatment. The patient had pelvic rectal prolapse. What we have here is, it's very mild. Let's scroll through all these images here. A little bit of anterior rectocele, and that's the only pre-surgery images that we have in our system. But in the interim, she had severe rectal prolapse, and so the patient had an Altmeier procedure. After the Altmaier procedure, the patient came back with recurrent prolapse. So I wanted to share what an Altmaier procedure is. I'm just going to scroll over my Google images here. So here, this is in an Altmaier procedure, and I'll show you the MR findings for that. They do this for severe rectal prolapse. And so what I learned from our colorectal surgeons is, they only classify as prolapse if it's externalized. And so here you can see cartoon, the patient, the rectal prolapse, you see the rectal prolapse, and they do this in severe cases. So they completely externalize it's a perineal approach. They externalize actually the entire course of the sigmoid, essentially, like take it all out, and then they resect it. And what you end up with is a coloanal anastomosis. And that's what this patient had subsequently, like multiple years after the Defecogram that I just showed you. So, and this is really helpful in knowing that this is what this patient had, because it changes your interpretation of the MR. I didn't read the study, but the patient couldn't hold in the contrast. So this was an incomplete MR Defecogram, which was performed for recurrent rectocele. The patient doesn't have a rectum anymore. I mean, the surgeon said that like it's all gone. It's essentially just a coloanal anastomosis. So when you look at the MR, there's all this bowel here in the presacral space, right? So now you have kind of when I first saw this MR, when I reviewed it during the pelvic floor conference, I was like wondering what this was all. And so then that was due to the post-surgical nature of it. So what you have here is there's no rectum. So this is the sigmoid that, not the sigmoid, the descending colon essentially is like a coloanal anastomosis. And this is done in severe cases. The other surgery that they do in setting of rectal prolapse is called a Delorme procedure, and this is what a DeLorme procedure looks like. So in contrast to the Altmeier, with the DeLorme cases, recurrence is much higher. So they externalize the prolapse, and they like they kind of plicate the muscle so that it kind of shrinks it, kind of accordion. It compresses it to reduce the kind of the prolapse. And this can be done, but the recurrence rate is higher compared to the Altmeier procedure. So this patient, the only option now that the patient has, because for the recurrent prolapse, is now just an APR. So the surgeon that's what the surgeon's going to offer her, is like just to have a colostomy, because there's no other options, when they failed the Altmeier procedure. So that was a lot of pelvic floor like surgical knowledge that I became aware of thanks to my colorectal colleague.
Pretty cool case and sad. Should I go? All right, so this was a acute case from this past call. Patient, I forget why the scan was done. And basically we got, I got the report, the prelim report from the trainee. And the trainee said, subcentimeter cortical hypodensities, too small to characterize, the standard, right? And then when we looked on the prior, which was done a few weeks before the current, you can see that these are non-existent, these little hypodensities. You see it? Like right there. And when you look more closely, some of these are not really rounded, they're more linear. You can see there. And then finally, there's a new splenic infarct. So this patient somehow is thrown emboli and has a little, patient has a splenic infarct, and these little hypodensities are not our usual, TSTC, who knows what's happening, but probably additional infarcts, less likely pyelo. Just a little cute thing. But sometimes, I know we're like kind of see them and just dismiss them in our head, but sometimes a little investigation is helpful. Okay. Eye test is, it is not an eye test. It's just, this is not a diagnostic dilemma or anything. It was just, this patient unfortunately lost the entire colon. So we have, a clear path for this. And I don't think I've ever seen such a great example of this entity with a path. So I just figured I'll show it to you guys. So this patient has just florid pseudomembranous colitis, and to the point where she has, the patient had to lose the colon and underwent the entire total colectomy, so you can see.
I always say the prettiest colons are C. diff colitis colons.
I mean, it's visually very pleasing, right? And you can see like the thumb printing on the coronal. And I want to the scout so you can see. Hold on. This PAX is like really bad at like changing identification, but you can see here the thumb printing on the plain, what we would see on the plain film, right? And this is the equivalent of what, exactly what's causing thumb printing on the on CT. You can see these just marked thickening of the colonic wall. Okay, and then my You can see, again, not an eye test, right? Just innumerable lesions in the liver, all with diffusion restriction, kind of hypoenhancing. You can see them nicely on pre-contrast. On CT, I'm sorry, MR, about 6 months ago. Hold on, let me just, you can see that the liver looked pretty much normal. And then here's a PET, and you can see that these things are quite PET avid. So, with these, the differential obviously is wide, but this was path proven lymphoma. And he or she, you can see a little bit of lymphadenopathy elsewhere. And yeah.
Impressive.
Yeah.
This patient presented to the ED with abdominal pain, abnormal LFTs, and this was the ED CT. No priors. So there's your coronal, and then here's your axials. Here's coronals again. Any thoughts?
Nelly, is there some soft tissue in the CBD at the hilum?
Yeah, so let me go back to the axial. Like here, maybe?
Yes.
Yeah, so the patient, then any differential considerations that you would?
No history of cholangitis.
Initial presentation, no, correct, no history of cholangitis.
Would worry about a malignancy first, right?
Yeah. So the patient underwent MRI, MRCP, and there was indeed a lesion right there on the MR, and then here are the pros cons. You see it right there. And then the MRCP images right here. Maybe give you the T2 axials. Any thoughts? Here's the
Nelly, any
bathroom.
pre-existing cholangitis, like
Mm,
RPC with now cholangio?
No,
No?
no existing PSC. But yes, cholangio is in the differential, and then the other differential that was given was IPNB. This is patient underwent an ERCP, and you can see that filling defects right there, pretty long segment in the right hepatic duct. And it came back path proven low grade IPNB. So this is a paper from AGR. Let me shrink this a little bit. On IPNB, and then kind of the imaging, clinical, and path features. So there's 4 histologic variants. The most common is the pancreatic biliary, and then there's the pancreatic version, and there's a biliary version. So this is a biliary IPNB. And I think the important takeaway from this table is the biliary IPNB, over 70% of the patients harbor some like invasive carcinoma. And that's why these are typically surgically treated. Whereas IPMN, which is the pancreatic equivalent of biliary IPNB, only about 20% have invasive carcinoma. So these are typically monitored, and we have various societies recommendations for follow-up. But in the setting of biliary IPNB, these are typically surgically corrected or treated because of high incidence of invasive carcinomas. This patient didn't have invasive carcinoma, at least in the ERCP, the tissue that they had, but these often go on to get partial hepatectomies, things like that.